Hey, good to see you. I'm sure you can relate to this. There are a lot of motivated runners, and those motivated runners will ask to do just about anything to get back to running. And so, as you get all these questions, you want to be able to advise these runners, to be able to give them the best information to help them get back to running. However, we've also seen those runners who are not indicated for an observational gait analysis. So today, we're going to go over some of the top reasons why someone should not participate in an observational gait analysis or running gait analysis. Let's get into some of this important information and talk about it a little bit more. So first off, whenever we think about doing an observational gait analysis or running gait analysis or walking gait analysis, it's really important to think about the patient's medical history. And that's the first thing that we should clear to make sure they're safe, to make sure that they can participate in a running or walking gait analysis. Particularly, a couple things come to mind that we'd want to be careful for. And some of these things would be a contraindication to that patient doing a running or walking gait analysis. One of the important things we think about are complications like cardiovascular complications or comorbidities, diabetes, maybe they're having dizziness or blurred vision, or maybe they're just taking medications and those medications are altering their ability to walk or run safely. We want to be really careful about these issues because there's a lot of them that can get compounded, and unfortunately they can have some really negative side effects for patients. For example, some of those cardiovascular complications can result in either a heart attack or stroke, and that's certainly nothing we want for a patient to withstand doing a walking or running observational gait analysis. Some of the things you might want to be careful when you're looking at a past medical history is things like, is a patient taking a beta blocker, for example, or maybe they're taking an ACE inhibitor for their heart or to control their blood pressure. Those are some important things to look for because if they are taking those medications and maybe with the ACE they are exhibiting a cough or dry cough that's preventing them to be able to run safely, or maybe with that beta blocker they're not able to really perceive how much exertion they're giving the running effort because it's limiting their heart rate and elevation in their heart rate. We want to be careful not to stress those patients too much. Also, we can always consider working with the primary care team or internal medicine team or physicians of the patient to make sure that they're safe and have them cleared for running or walking prior to seeing that patient as working with a medical team. Another issue that can be a comorbidity or something that we want to be really careful for patients is the diabetic population. And some of those diabetics, certainly we want to be careful with how high or low their blood sugar levels are. Certainly if they are too low and then we have them exercise, that can create them to be even lower and some really bad side effects can happen as well. So we really want to be careful, and we especially want to give some extra attention to those patients who are diabetics who are also on new drug therapy regimens. For example, maybe they're taking metformin and they're new to taking metformin and they're not sure how exactly it's controlling their blood sugar levels, and we want to be careful if they're going to be running or walking how that might affect their blood sugar levels and their safety to run or walk. And lastly, obviously, if a patient can't see properly or is having blurred vision, is dizzy, we want to be careful about all those things. So doing a nice comprehensive medical history is really good. Personally, I always take heart rate, blood pressure. I take pulse ox to make sure that patients have safe levels before I start them running or walking. And I do this just as a part of a routine to make sure patients are safe prior to getting on the treadmill. At least I can put it down and at least I can check it. And I want to make sure to check it to make sure those patients are safe. Now, outside of the medical background, there's a bunch of other things that we want to be careful for. And one of those is any musculoskeletal injuries or contraindications of the musculoskeletal system to performing an observational gait analysis, either running or walking. And you might be thinking to yourself, well, I am a musculoskeletal expert. I can figure out what patients might need and whether they'd be ready for a running or walking gait analysis. Well, there's some intricacies here. And yes, some of the obvious ones are obviously if a patient is suffering from a bone fracture in the lower extremities, maybe a torn tendon or ligament, maybe they've torn an ACL or a meniscus, or maybe they even have a herniated disc. Those are all really good contraindications to say, hey, you know what, you're not safe. I don't want you to run or walk. Or maybe they're having neuropathy or pain and numbness and tingling and weakness going down their extremities, legs, and particularly maybe they're having some foot drop. We want to be very, very careful with them doing a running or walking gait analysis. Maybe the walking gait analysis is okay, but the running gait analysis isn't. And this is where your clinical decision making comes in. But there's also some gray area when it comes to existing injuries and musculoskeletal injuries and the readiness to have a walking or running gait analysis. For example, a patient's coming back from an ACL and they're recovering from an ACL reconstruction. When do we have them run? When do we look at how their running actually looks and observing their gait, and how do we get them safely? Well, there's a number of things we can do. We can do objective tests, we can do objective measures, which may be best for that ACL patient, which we'll touch on in just a little bit. But also, we might want to do a walking or running gait analysis for the patient that maybe has patellofemoral pain syndrome or IT band syndrome or maybe greater trochanteric pain syndrome. And we might want to do that in the diagnostic aspect to be able to decide, hey, is this person causing more injury when they run or when they walk? Or are they re-aggravating symptoms? Or lastly, I can't figure out how to actually get this patient to 100% and I need to do a walking or running gait analysis to be able to break down their mechanics, their biomechanics, and actually understand for diagnostic purposes what we need to do to get them to 100%. Now, there's really two schools of thought here. And I've touched on the first school of thought a little bit already. The two schools of thought are either you wait till the patient's injury is 100% resolved before ever doing a walking or running gait analysis, or you do the running or walking gait analysis in a short period of time, meaning maybe you have them walk for 5 minutes or run for 5 minutes if they can withstand that. Maybe their injury doesn't get flared up until maybe 10 minutes of running or 15 minutes of running. Again, that's where your clinical decision making comes in. So we have them walk or run, and then we can be able to evaluate it. But with those patients that we're waiting until the very end and they're completely resolved, obviously there is some benefit there. We don't have a risk of them getting re-injured by walking or running. We're not holding that risk when we're evaluating them, and certainly we want to make sure they're 100% better. When they're 100% better, then we take a look at their walking or running, and obviously we can use that to prevent future injury or re-aggravation and to also help aid in any plans of care that we might be prescribing to them. And then lastly, when we look at some of these trends and when we look at some of the newer research, we actually see more and more people doing a combination of a running or walking gait analysis during the treatment time or during the plan of care, and not until it's all the way resolved. So, some of the emerging research out of the Cleveland Clinic is showing that they're really encouraging people to do a running or walking gait analysis as soon as that patient is able to, at least for maybe even 30 seconds or a minute, because that gives us valuable diagnostic data that can help that patient improve. So we are really cognizant of when we're doing running and walking gait analyses, and the moving trend is to get them earlier and earlier because they provide so much helpful diagnostic information. But at the same time, we want to be careful not to aggravate those symptoms and certainly not to cause the patient more damage or even long-term damage. Now, we've talked about musculoskeletal, we've talked about medical issues that might be contraindicated, but what are some of the other things out there? Well, certainly there's runners' current training schedules, and certainly there's things that might affect how you might want to approach a running or walking gait analysis. And this is for a lot of those higher performance athletes, some of the folks that might be coming in and doing really high mileage. So we want to be careful when we're doing a walking or running gait analysis and then asking them to make changes or adjusting or retraining their gait or potentially giving them corrective exercises or changing their footwear, the whole list of interventions we can do. Now, obviously, you can do a gait analysis and then you can go back and say, hey, we're not going to make those changes till later, until it's a good window in your training schedule. And that's one way to approach this. But we want to be really careful with the patients or runners that are certainly have a race that's coming up very soon, or potentially are running high mileage, or are running really fast. And this could be walking really fast. This could also be walking high mileage. So it applies to both sides. But we want to be really careful because they're doing a lot already. We're asking them to change, and if they want to keep that high mileage or that fast speed, or if they want to keep that race date, we are now asking them to change a lot and making a big change on their musculoskeletal system all at once. That big change may not hurt them or aggravate symptoms or damage their musculoskeletal system if we did that independently at a lower volume. But at that high volume, they just might not be ready for it. Think about heel strike versus forefoot strike for a runner. If all of a sudden someone comes in with a heel strike and we say, hey, we want you to forefoot strike only going forward, and that's the only thing they're going to do, and you're going to change that starting today, they're only going to land on their toes. Well, that's going to put a lot of stress on the calcaneal tendon or Achilles tendon, the calves, gastrocnemius, soleus, hamstrings, the list goes on. So certainly we want to be careful. And now let's say they're doing 100 miles a week, they're running 6-minute miles, and they're also have a race marathon that's coming up. That's a lot of change. That's a lot of impact on their musculoskeletal system. I'm worried they might get injured. So for me, I use a couple things in my daily practice that are good guidelines, and this is an area where the research is still needed. There is more research needed in this aspect because we don't really have firm and fast rules. I'd love to see some of the research come out here a little bit more, but certainly with patients that have a race coming up in the next month or under a month, I'm very cognizant of doing a running gait analysis. In fact, I usually don't advise them to do it within that month of a race. Or if they're training over 75 miles per week, that's another issue I'm concerned about. I'm concerned, again, that high mileage is going to add up and make a significant change to their musculoskeletal system. Even if it's for the positive, it might actually damage them in the short term or potentially even long term. And if someone's running a sub 7-minute mile, either in training or aiming for that on a race, I'm very, very hesitant to do a running gait analysis. So I hold them back and I say, hey, let's find a good time, a good window. Let's wait till after your race, and then let's have a couple weeks or even a month or maybe even 2 months where we're ramping up and having you actually be able to implement these changes safely. And then lastly, we think to ourselves, how can we make sure someone is ready for a running gait analysis? Maybe they're a good candidate. We talked about that ACL patient. Maybe they're a good candidate and they are a patellofemoral pain syndrome patient that you want to do a running gait analysis on, but you're just not sure, can I have you start running? Are you ready to do running or walking? Or what are some of the testing measures we can use? And there's a lot of emerging evidence here, and it's some really cool stuff that's out there. Some of it's coming out by UCSF or UC San Francisco. Some of it's coming out by USC. And so there's emerging data, and I am excited to see more and more of it. On the online blog, I put a bunch of links, and I'll try to put those links in the description here too, but solutionseducation.com, if you look at the blog, you can see a lot of the links in terms of tools and assessments you can use. Personally, I think these questionnaires are great, but there is no magic one questionnaire that's going to work and give you the answer and pop out yes or no. It's always up to your clinical decision making. So in this regard, I always put a couple things I like to put together, and I'll name them off here, and obviously I can't share links to you verbally, but the functional movement screen is one that I really like. The PARQ, or the physical activity readiness questionnaire, is another really good one. I love doing single leg balance tests, lateral step down tests, calf raises to fatigue, drop jump tests, and I also really like assessing single leg squats as well. So those are some of the things I'll look at. I have a lot more that I look at as well, but again, you're getting a comprehensive functional movement view and a questionnaire, and you're starting to get an idea of whether this person is appropriate. Really, a lot of these are designed for running. Some of them are designed for walking as well. So take a look at those links, and they can be helpful, especially for some of those patients that might be borderline, or you're trying to get a better picture of whether they're appropriate or not. And there's many ways we can become more confident in our running gait analyses and be able to understand who is indicated or contraindicated for running gait analysis. And so if you want some more resources, you can always check out solutionseducation.com. You can go ahead and look at the courses. The Essentials of Running Gait Analysis gives a great concept of not only what are some of the tests and measures you can perform to look at whether someone's appropriate to walk or run, but it also goes over some of those contraindications we talked about before, and it also gives you the tools you need to be able to perform, assess, and start your own running gait analysis clinic. We hope you gained something from this, and until next time, we'll look forward to seeing you. If you have any questions, send them over our way. We'd love to answer them. Until next time, stay safe.